Welcome to Medicine Handy Point. Today we will discuss a very important topic, which is pyrexia of unknown origin. It is a very challenging scenario in the medical ward. So let's first define it. Um, it should have fewer of at least 3 week duration. Um, the fever should be 38.3 Celsius or 101 Fahrenheit on several occasions. Diagnosis is not made after 3 OPD visits or 3 days of hospitalization. If these three scenarios are met, then we can label a fever as pyrexia of unknown origin. What are the causes? So let's first discuss. Mostly infectious causes, which account for 30% of the pyrexia of unknown origin. In infection, hidden infections like sinusitis, dental infection, infective endocarditis, tuberculosis, liver abscess, prostatitis, bone and joint infections, mosquito related like chronic malaria, zoonotic infections like brucellosis, Q fever, psittacosis, and leptospirosis. Leptospirosis occur in a patient who are dealing with the sewerage cleaning. Mostly sewerage cleaner get this disease, while brucellosis usually by the patient who deals with the cattles. Then is STDs like chlamydia, gonococcus, and syphilis. And in immunocompromised patient, we should focus on HIV, CMV virus, and fungal infection. Now, in connective tissue disease, account for 15% of pyrexia of unknown origin. So most top are SLE, rheumatoid arthritis, and Sjogren syndrome. Vasculitis, particularly giant cell arthritis with polymyalgia rheumatica, should be focused on. Polymyositis and dermatomyositis, adult onset still disease which have a high grade fever, joint pain, lymphadenopathy, and it has got Yamaguchi criteria as well. Then familiar Mediterranean fever. So these condition comes in connective tissue disorders. Then is malignancy, which accounts for 20% of the cases of pyrexia of unknown origin. It includes lymphoma, atrial myxoma, usually missed, renal cell carcinoma, or other carcinoma as well. Miscellaneous causes accounts for 20% of the cases. These includes drug fever, so mostly beta-lactam antibiotics, cardiovascular drugs like quinidine and methyl-dopa, antineoplastic drugs, and CNS drugs like phenytoin and barbiturate. Thyrotoxicosis can also cause fever. Sarcoidosis can cause it. Cirrhosis can cause it. Inflammatory bowel disease can cause it, and factitious fever, which means the fever is not there but the patient is pretending to have the fever. Undiagnosed cases mostly occur in 5 to 15% of the cases when, despite being thoroughly examined and thoroughly worked up, the cause is not found out. Investigation which we should do in pyrexia of unknown origin, we should start with peripheral Smith with MP and ESR. We should do RBS, RFTs, LFTs, and chest X-ray. Blood cultures, we should do urine RE followed by urine culture and sensitivity. Connective tissue disorders workup, ANA, RA, ANCA, and ferritin. Lymph node biopsy if lymph nodes are found to be enlarged. PPD test for hidden latent tuberculosis. Echo in case of infective endocarditis and atrial myxoma. Ultrasound abdomen and pelvis as well. HIV, bone marrow examination if there is a suspicion of the bone marrow involvement, and some specific other drug tests like CT, thorax, abdomen and pelvis, MRI, bronchoscopy and colonoscopy. So these are the minimum and investigation which should be done before labeling somebody as a pyrexia of unknown origin. I hope you liked the video and thank you for watching, and please subscribe to the channel.